All right, everyone, thanks so much for joining. My name is Christy Wallace. I'm the director of the Brain Center for Community Engagement. My partner in the Brain Center, Julie, is also here, and you will hear from her at the end of tonight's session. In case you haven't seen, this session is being recorded. It will be posted on our Brain Center YouTube channel. It'll also be posted on our event page. Everyone will remain muted for the duration of our presentation, but please feel free if you have questions or need a point of clarification for anything, just put it in the chat box and we can address those as they come up. And then we'll also have time right at the end for Q&A as well. So for those of you that this is your first session that you've attended as a part of the Civic series, thank you for joining us. Welcome. There are 5 previous sessions that we posted over the last month that you can access from our event page, which is www.bw.edu/civic. You'll find the recordings as well as a list of recommended resources for continued learning and action from each of our presenters. Just last night, we had a very lively discussion and lively session with Dr. Barb Palmer, talking about voting rights and the Constitution. And we're really looking forward to the conversation tonight. Just as a reminder, this event is rooted in the standards that are established by BW's Community Standards of Conduct. So we expect that this is a space where we can engage empathetically, respectfully, and thoughtfully together. Just a little bit of background on our 2 fantastic presenters tonight. Dr. Swagata Banik is the former chair and professor of public health and prevention here at BW. Recently made dean of graduate studies and research, so congratulations to you. Serves as the director for the Center for Health Disparities Research and Education at BW, has taught public health, global health, health and social justice, urban health and disparities. Dr. Amelia Lombardi is the new chair of public health, an associate professor, has a doctorate in medical sociology and has been involved in HIV prevention research and examining health disparities among racial and ethnic, sexual and gender minorities for over 15 years. And also has been teaches a lot of learning classes and very involved with the Brain Center as well. So we appreciate both of your support and your ongoing engagement with all of our programs. So tonight's session was one of the first, honestly, as we started designing this series and kind of curating sessions and topics. It was simultaneous to the time that the city of Cleveland was voting to declare racism as a public health crisis. And so we are so glad to have you 2 here to help us think this through, what this means, and what this means for our region as well. So thanks for being here, and I'm going to turn it over to Amelia and Swagata.
Okay. Swagata and I are going to be splitting our talk. I'll be starting first, getting things introduced and probably setting the stage, so to speak, and then Swagata will come in and talk, and we'll give more details regarding the health impact of racism and so forth. And then we'll leave time for discussion. So if people have general questions, it's good. We'll answer those at the end. But if people have any specific questions regarding a particular topic or particular slide, we'll try to address those at the time as soon as possible. So with that, I wanted to say this is what our topic is, looking at this issue of racism. And I think the original title is Racism as a Public Health Crisis. I want to emphasize that more of an issue because, in my mind at least, crisis implies that people are just now realizing or dealing with it as a problem, whereas this has been a problem, been seen as a problem in public health for years now. It's just now it's getting a bit more attention. And so with that in mind, kind of just setting the stage in that we, in terms of how we talk about racism, we can talk about really in a few different ways. First, we can talk about racism as being more an individual factor, individuals' belief about race and individuals' behavior regarding race. And we've we have numerous examples publicly about individuals acting racist. Um, in a lot of what we're going to be talking about, though, we're going to need to talk more about the ideas around cultural racism, and more specifically, the idea of systemic racism. Now, cultural racism is a set of beliefs and expectations that really permeate our society. An example of that, especially in health, is many physicians tend to believe that African Americans have a much higher level of pain resistance, and as a result of that, they're less likely to have their pain being taken seriously, and they're less likely to be provided pain medication for whatever problem or health problem that they're experiencing. Um, and there's a host of these other kinds of issues. In regards to systemic racism, these are, again, those kinds of cultural beliefs that get embedded within our institutions. And it perpetuates inequality in our society, but in a way that many people are not conscious of. This is just how things work, and people don't really think about it. When you see people just go on autopilot, the system just kind of acts that way. And so we need to really think about systemic racism as these kind of unconscious, unnoticed actions that occur in society. And the specific one, I think that has probably a large impact on our society is this concept or this idea of redlining. Historically, redlining was an event where it started with the Federal Housing Administration in 1934. This was established to increase home ownership in the country. Just after the Great Depression, the goal was trying to build up the country, and so the federal government initiated this Federal Housing Administration to help build homes, and to move people into new communities. However, as a policy, they would not loan money or support loans to communities of color or immigrants, and especially prevented communities of color and immigrants from moving into predominantly white communities. And they did so by this idea of redlining. That is, they've literally outlined a map in red to say that we are not going to loan people money or support loans in these areas. And that action had a long historical impact in terms of what we see in health today. So kind of using this idea and thinking about what impact, say, redlining has on society. So first thing, I'm going to be showing quite a few maps to kind of show this. So first map. This is something that you may or may not have seen in the past, but this is life expectancy in Cuyahoga County. And so areas in red are the areas with the lowest life expectancy, with the darkest red being less than 73 years of age, and then the darker green being upwards of 82, 83 years of age. And two areas that a lot of people tend to kind of compare is Huff, which is, let me bring this little pointer here. Huff right here, and Lyndhurst right here. Really, in terms of the map, these are not areas that are far apart. However, if you're looking at life expectancy, very great difference between the two. And reason being for a number of reasons which we'll get into. But this is the first map I want to show you. The second map is this is the map that shows the areas that were redlined back in the 1930s. So here's the same kind of areas here redlined. If you're living in this area here, you couldn't get help to get a loan or get economic resources to purchase a home, to renovate a home, or anything else. whereas in these blue and green areas, you're much more able to access those resources. And so, again, Huff, Lyndhurst. And so the idea of redlining as having a long history really has had a long reach in terms of how it's been impacting the health of communities here in Cleveland and other parts of the country. And so kind of give you more example of what this kind of looked like. Now this was taken from documents, banking documents, FHA documents, where they go in and describe properties. And what's notable here is talking about 1939 East Cleveland. And this is an official document. This is what's used to decide whether to provide people in these communities economic resources. So again, this is policy. The apparent future for this area will be an increasing occupancy ratio of Jewish, Italian, and colored with steady fall of price values. So immigrants and people of color within these communities could not access sufficient resources. And so this impacted the community at this time. They also look at other forms of policies, the idea of racial restrictions, in that for the longest time, the federal government, state and city restrictions allowed the use of what's referred to as racial restrictions. That is, putting verbiage into contracts that state that people cannot sell, lease property to anyone else who are not Caucasian. So this also kind of led to funneling communities into different parts of the city. And so individuals cannot move, or people of color cannot move into communities, white communities, because of a lot of these restrictions. They couldn't access economic resources in those communities that they were allowed to move into, and then causing a lot of housing issues, which we still see today. So again, this was back in the 1930s. This kind of continued until, for the most part, well, let me back up. Racial restrictions were found to be unconstitutional by the mid 1940s. However, redlining itself continued into the 1960s until the 1968 Civil Rights Act, the Title VII, which put an end to discrimination in housing. So, in terms of the FHA, 1934 to 1968, having this long history that's been impacting these communities. But what's also crucial is that even after 1968 and was seen as illegal, that's when perhaps they used other excuses to prevent banks to prevent lending to those communities. So rather than not being provided economic resources because of the area which you're living in, or race for that matter, they find other excuses, such as, well, the property values in your community is too low for us to rent, or you don't have enough economic self-sufficiency for us to loan you money. And so while the initial racist policy ended, other policies continued that still act in a way that's made those same policies persist, but people are using different terminology through the years. But thinking about how this has been impacting health. So this is Baltimore, and this is actually some slides that my colleague Laura Hopkins have worked with in the past. So Laura, if you want to say anything regarding this, please feel free to speak up, especially if I say anything wrong. So this is Baltimore, and this is their red-lined areas. And so sitting here, we're looking at this idea of food deserts, basically areas where people cannot access healthy food. And in regards to general statistics, a food desert is defined as any area where a third of the population lives 1 mile or more from a supermarket in an urban area. And so these red areas indicate, areas where people can't access or don't have a supermarket close by. And you might think, well, 1 mile, that isn't too much. But again, thinking about individuals who may not have reliable transportation or may need to utilize public transportation for food, having to travel more than a mile on the bus or by walking could be a bit difficult in terms of accessing. And taking this even further, while grocery stores are limited, these other things, these blue dots and these green dots, indicate corner stores and fast food stores. Basically, areas where the kind of food you can get is very cheap and very unhealthy. And so, in a lot of these food deserts, in a lot of these areas, you're seeing people not able to access healthy food. And then you could kind of look at it here in terms of life expectancy, how that's impacting life expectancy. So this idea of redlining has a long reach. And one thing that we look at in regards to this, is thinking about this, is what we call social determinants of health. And this is from the Kaiser Family Foundation, and they outline economic stability, neighborhoods, education, food, social and community contexts, and healthcare system as being social determinants. We can talk about how redlining has impacted all of these and how all this has, in the end, impacted the health of these communities. So, moving forward, thinking about this. So, for redlining, impacting economic resources. Due to redlining, you can't use your homes to leverage loans for creating businesses, or people who are looking to open businesses or places where people can be employed do not go into areas that are redlined, perpetuating the lack of abilities for people for employment or for economic resources or advancement. Looking at neighborhoods, because of the economics that they can't access loans to improve homes. There are limited resources to build parks and other amenities. And there's a greater exposure to environmental harms. One thing a lot of people are finding is high rates of asthma in these communities, high rates of lead poisoning as well, because they don't have the resources to perhaps repaint homes. You talk about lack of resources for education, where there is insufficient tax base to fund schools. If schools are funded by property taxes, if your areas have low property values, you're not getting sufficient money to fund schools. And again, you can't leverage your homes for education, to go to college. There's other areas where you could. As we mentioned, in these redlined areas, you lack access to healthy food. Grocery stores do not open in these neighborhoods, but you see a lot higher representation of convenience stores and fast food. And we can think about, again, the impact of the community as well, where you have people living with high levels of stress due to economic issues, high levels of stress due to discrimination that they're experiencing. And all these leading to impacting health and their access to healthcare, where they're much greater exposure to health issues and much limited access to healthcare resources. Which, and again, really want to conclude with, for my part, is that actions do not have to be conscious in order for it to be racist. So the systemic racism means that these actions are being persistently active with no one being conscious. These are just institutions just acting in what they perceive to be irrational ways, but these ways are negatively impacting these communities in so many ways. And so with that, I'm going to um, bring in Swagata to talk about the, the direct health impact of these issues.
Thank you, Emilia, and I want to also thank you all for being here. It's after 7 o'clock on a weekday after all day work, so it shows the commitment that you have towards all our efforts towards equity. And I especially want to thank Julie and Christy for really hosting us all and doing these initiatives for really sensitizing all of us in this issue. I wanted to just talk a little bit about how we define public health and population health. There are three major components that we really focus in public health as is the prevention of disease, and in the population health realm, which is becoming an emerging areas, is how to improve patient satisfaction and also decrease the cost of healthcare. So in this triangular approach of population health, I think this particular topic of injustice, racial inequity, has a major role and major play. I would also like to expand the idea of racism a little bit, define it a little bit more broader. Historically, we have seen a direct impact of a systemic racism and institutional racism through the Tuskegee study, and most of us who are in the healthcare field, even in beyond healthcare field, in the social and psychological field, have all known about Tuskegee study that has happened in 60s. And the impact of the Tuskegee study is we are still dealing with in the contemporary today's areas, because we still have challenges in attracting and recruiting individuals from minority background in clinical trial. We can talk about Tuskegee and this impact of institutional bias and how that affect public health for hours, but what I wanted to just touch upon is that this is not, as Emilia started this conversation this evening, that this is not right now that we are becoming aware of. This has been happening for ages in our country. If you look at all the health data, health outcomes data, especially in the chronic disease outcome, actually in most of the diseases, even in today's COVID-19, you will see the mortality rate is much higher among minority groups. This is just an example of cancer mortality. Nationally, African Americans are twice more likely to die from prostate cancer, and then 40% more likely to die from breast cancer. In Ohio, African Americans had an 11% higher age-adjusted cancer death rate in 2012. Disease after disease, they have shown, we've shown there has been a lot of studies that we have concluded based on years of data that social determinants of health, one of the primary determinant of disease and our health outcomes. Any health outcomes we talk about, they're directly related to the social determinants of health. And why is beyond why it is important in population health is because the chronic disease alone cost in Ohio between in 2010 it was $25 billion and is expected to cost close to $50 billion in 2020. So that itself is also driving the healthcare industry to start addressing social inequity that we experience across the country for certain groups of populations. This is a slide to show that how social determinants of health really affect our overall health outcomes. The studies after studies have concluded that our overall health outcomes, 40% of our overall health is really driven by social and economic factors. Health behavior, which directly related to our social and economic factors, contribute to 30% of our overall health. physical environment where we live, our accessibility to the food and the activities that we can engage in contribute to 10% of our overall health, and 10% of our health is determined by genetic structures and biology, which is not modifiable factors. Only 10% of our overall health is contributed by clinical care, which traditionally we defined as healthcare in this country. So the countries that have invested in all other areas like social factors, health behavior areas, and the physical environment have shown much higher population level health outcomes than United States. As I said, I wanted to expand that conversation to also include some other kinds of biases that we oftentimes ignore and do not talk about in the context of race and racial injustice. So one of the examples I want to talk about is microaggression. So microaggression, oftentimes, what we refer to microaggression is these everyday manifestations of environmental behavioral slights that sometimes happen unconsciously or sometimes intentionally. It has both internal manifestation, has psychological manifestation. This has contribute to a long-term exposure to microaggression. There are studies that shown that long-term exposure to microaggression contribute to intrusive cognitions, which means the internal dilemma that we all deal with day after day, month after month, years after years, to analyze those slights that we receive as a group of minority individual, whether they were meant as a intentional, unintentional. What does that mean? Because of that, our cognitive analysis, there are data that show that it has a direct impact of our mental health. What do we mean by microaggression, and who experience microaggression? Any marginalized group, any minoritized individuals can be subjected to microaggression. That can include the racial, gender, sexuality, disability, and microaggressions in all other areas. So the microaggression. So what is racial microaggression? So there are three types of broad category of microaggressions: micro insults, micro assaults, and micro invalidation. So micro assaults are basically those old-fashioned racism. So somebody who is showing up to a party wearing a Ku Klux Klan costume, which really is nothing but a micro assault to a certain towards a certain group. Sometimes the micro insults can be intentional or unintentional, but most cases the microaggressions occur really without our awareness, especially in a day-to-day environment. It happens without our awareness. So why I'm talking about this, that I think we have to be careful, or we should be aware that our delivery, our expression can have a serious health impact to the other person. So microaggressions are the belief and the commonplace daily verbal, behavioral, and environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, and negative racial, gender, sexual orientation, religious slights, and insults to the target person or a group. As I said, that it can be the perpetrators can be unaware, or they're usually unaware that have engaged in this kind of a exchange. And there are some studies that have shown that in academic settings, students of color often describe migration aggression as a pattern of being overlooked, represented in the overall discussion of race, inequity, and aggression and health. Some of the commonplace microaggression, and if you look at my skin color and my height, those of you know me, and my accent, obviously, every time people ask me, where are you from? I'll probably if I put a penny in the jar, every time I hear that I'll probably have a couple of $100,000 by now. That's the exaggeration, but what I'm saying is those are those, even though it may not be intentional, but to the receiver, it can come across as a insult. So I live in Cleveland Heights in Cleveland for 20 years. So I still, every other day, people ask me, where are you from? I said, Cleveland Heights. Where are you really from? So that's an example of microaggression. Or you have, wow, you have a nice accent. So that implies that because the way you look, because of your nature, you cannot speak properly, or you are not intelligent. So this underlying connotation, underlying expression that really affect how we process them, and that has a long-term effect on our mental health, on our academic productivity, on our work productivity, on our sleep pattern. And cumulatively, they have a long-term effect on our overall health. So some of the examples, for example, asking women of color about their grooming habits, or touching an African American woman's hair to test how their hair looks like. Or commenting on a nice accent that I was talking about, or calling a transgender faculty member or a colleague by their birth assigned name or pronoun, despite correcting that aspect of that. So these are some of the examples of microaggression, and I think many of us have experienced those kind of behavior on a day-to-day basis. I don't want to go. And just to give you some examples, well-documented increase in the discrimination and harassment of Arab Americans after 9/11. And there are studies that have shown that Arab American women in California had an increased risk of low birth weight and preterm birth in 6 months after September 11 compared to pre-September 9/11. Other women in California had no similar change in their birth outcomes. And some of this data has really explained and linked to the experiences of those microaggression on a day-to-day basis. Another idea, another concept that has becoming very relevant, and especially in the public health literature and public health field has becoming more and more prominent, is this idea of intersectional oppression, intersectionality. So even if we talk about racial discrimination, the person's identity as a race is just one dimension of their identity. That person may have other minority identity as well, in terms of their gender, in terms of their class, in terms of their economic ability, in terms of sexual orientation, or their gender identity. And all of these identities intersect with each other and has a cumulative impact on how that individual process their identity as a whole. And one's experiences one dimension may also impact experiences on the other dimensions. So these multiple identities, these identities as interconnected, and then necessitate as a point of in the context of their whole and intersecting individuality. And this whole identity of intersectional oppression was initially started with feminist movement, and then it brought to the forefront by Africa. There is the well-known African American psychologist Crenshaw, and it really started with this whole idea that in terms of just one identity, the experiences related to one identity it doesn't explain our overall health outcomes. So what this concept really really talks about is that so for example, there are many different kinds of intersectional exclusions. So the same person may be accepted in a different one identity, but the same person could also be excluded because of their other identity, because of their disability, because of their immigration status, because of their LGBTQ identities, or other kind of race and ethnic identity. Also, intersectional identity, intersectional biases also include the other social determinants of health. So for example, poverty, class, housing status. So people, how we perceive somebody who is who may experience homelessness, or when we experience somebody who is homeless, their experiences and how that impact their health outcome may also be affected by these experiences of stigma and discrimination. So there are studies that have shown that impact of intersectional stigma increased the 2 to 3 time increased risk of high level of psychological distress, including depression and lower self-esteem, feeling excluded from the communities, which means the social resources that community provide, or the social capital that a community may present to the individual will not be accessed by this individual who experience intersectional oppression. Again, if we are talking about a university community, there are still we do not know a lot about, like, how does it look like in a university community. For a student who may be a underrepresented background, who may be African American, who may be gay, who may have a disability, these experiences in 3 different dimensions may contribute to their overall mental health outcomes, overall performance, overall academic performance in their academic areas. In my own research, I think both Emilia and I have similar kind of research areas. In my own research, what I have recently shown, especially among healthcare providers, I'll just talk before I end this part of our discussion. I wanted to just talk about what I have seen in my own research in India in healthcare providers, that the quality of care significantly compromised when the healthcare providers held stigma in terms of race, in terms of so my work with HIV and trans patients in India shows that the healthcare providers who held preconceived ideas about gender expression, about masculinity, about race, skin color, and class-related ideology have very lower healthcare service performance with their patients. Not only just trans patients or patients from the poor community, but among all patients. So that data shows that holding somebody who held negative attitudes towards this minoritized or minority segment of population, their performance, their healthcare performance, health service performance, really, in general, their health service performance are declined for all patients, irrespective of the type of patient. Obviously, if they work with the patient of one of those groups, there is a direct consequences on their health services. But it shows that the other patients also suffer. The same kind of research in other areas, in HIV areas also, we have seen HIV patients, those who report intersectional stigma based on their HIV status. So intersectional stigma can also be experienced not just based on race, gender, and those kind of demographic characteristics, but also the disease condition. So HIV patients, they experience stigma because of their disease condition. And we see African American patients who are living with HIV experience much higher level of stigma because of their racial identity, because of their geographic location where they live, because of the condition of housing they live, and also other health related behavior. So for example, if they are engaged, if they report substance use, for example, again, that experiences of stigma is even multiplied. And we see overall the same patients have much lower adherence to prescriptions, much lower adherence to their healthcare providers. And then, so that's one of so that's the ways that we see that experiences of stigma, bias, and discrimination. That's one of the example that impact overall health outcomes. How it includes, there has been several pathways. There are a lot of studies that are experienced. There are psychological pathways through mental health outcomes. There are biochemical pathways. So we know, at least we know that cortisol, the stress hormone, is one of the important biochemical component in the body that respond to our experiences of stress. Cortisol in a lower doses, in a lower level, has a protective role. But the long-term exposure of stress, that means long-term chronic accumulation, chronic secretion of cortisol, has a dramatic effect dramatic adverse effect on our metabolic aspect, on our metabolic abilities, on our sleeping behavior, on our fat processing issues. And there are data that shows that this chronic exposure of cortisol contribute to diabetes, contribute to obesity, contribute to cancer, and in other chronic conditions, bone density, reduction in bone density. So the stress pathway has been validated biologically, biochemically validated for a long time. But there are some other pathways, which is psychological, social pathways, which is because of our experiences of stigma, because of racism, because of other conditions, because of microaggression, our ability to access those social resources are diminished. So that's one of the areas that we see how health is affected because of the experiences of stigma. And then there are a lot of research that is going on that also establishing other definitive pathways between experiences of stigma, bias, and discrimination because of our racial identity, because of our other intersecting identity, and how both in a short term and long term it affects our overall health outcomes. So in conclusion, I wanted to just I just want to say that racial disparities in health are large, pervasive, and persistent over time, as Emilia was showing with those maps, with those data. Inequalities in health are created by larger inequality in society because of the lack of access to those social determinants of health, such as education, housing, and those areas has a direct implications on our health outcomes. And the racial differences in health reflect the successful implementation of our social policies, as the redlining is one of the great examples that we are talking about. And in overall, that's one of the major focus in the emerging healthcare is this population health and eliminating the health disparities, irrespective of political belief. We know that we cannot separate politics from public health, but we know that irrespective of political belief, one of the common point of agreement that we have to address disparities in our country, and those disparities we will not be able to address in our country and prevent the disease unless we acknowledge racism, its impact, its consequences, and how and the racism in different forms and different dimensions. So with that, I wanted to conclude, and I want to really have a discussion, because this is a dialogue, I believe. This is not a monologue. So we wanted to open it up for questions. Thank you.
All right. I see Agnes has a question about food pantries set up by the hospital. I think this is I know that Metro Health has a food as medicine
Yes.
program.
Okay, so Agnes, that's a great question, and I think it's a timely question. Do you think? Yeah. So Metro Health, and there are quite a few other hospitals in Cleveland area, is coming up with um, this initiative of having their own food bank, food pantry. I know, I mean, we work closely with Metro Health. So I can tell you that Metro is making a very significant impact with their food pantry. Metro also has, and we are very closely working through our MPH program. They started a program and initiative, or actually they have an office. It's called Institute for Hope. So this is the for the primary goal of Institute of Hope is to really address social determinants of health. So they have that. I think this is one of the model, and recently Mayo Clinic just came up with another initiative to really invest in social determinants of health. They have come up with about $100 million of initiative. But Metro has been really at the forefront of this initiative, how to incorporate social determinants of health within clinical systems. So the Institute for Hope, they're assessing every patient for social determinants of health. So they have like 12 ideas. So one of their primary is like access to healthy food. And then through their screening, so they're screening all patients about social determinants of health. And those patients who are reporting as a social food insecure, then they're connected directly to the food pantry of Metro Health. I also want to plug in here selfishly that we at PW, the Department of Public Health, my colleague Laura and I, we have just received 2 grants, one from Aetna Foundation and American Public Health Association. We are one of the 20 awardees in the country. It's called Healthy Cities Challenge, and one of our goal is to really train students, public health students, and community residents as community health and community health and empowerment navigators to connect those food insecure residents. We will be also doing community-based screening for food insecurity and connect those food insecure residents to existing food resources. So there are a lot of existing resources. So our goal is, instead of recreating the tools, we should be able to connect the resources to the needed families. So
And,
yeah,
and can I
yes.
add a little bit more to that? And these programs, again, are very, very important. And I think something that I think, Kelly Coble, you start looking at when you talk about other policy considerations. While those programs, the Foods for Medicine program and others are useful, I mean, there are still large systemic problems that need to be addressed. And you're really starting to hear more people talking about the idea of reparations a lot more, and what reparations would look like. Now, that when people say reparations, they mean trying to provide some systemic um, uh, resources to those who have been impacted by um, centuries of inequality, slavery, Jim Crow, redlining, so forth, and trying to find a way to provide uh, a better level of equity for these populations. And that is people are starting to have that conversation more. It's a big conversation, and but people are now starting to have that conversation.
Any other questions? So
Daniel has one about the healthcare protections for transgender people. What I've been told is that actually the recent court case, a Supreme Court case, that found that Title IX protections actually included transgender people, that provides some cover for transgender populations, saying that while the Trump administration is rolling it back, but the Supreme Court generally said that no, they actually do have protection based on Title VII. So, which in the end means that it could end up being, if this administration continues over multiple years, you may see additional court cases trying to argue, does the administration's ruling perhaps literally trump the Supreme Court's ruling allowing protection? So, but what I've been hearing from advocates is that the ruling actually provides some support for transgender people for healthcare as well as employment.
I think Kelly has a question that I think primarily relates to any thoughts on how we can expand our policy discussions locally and nationally to address these broader inequity discrimination issues with a view to their health impacts.
Right. That's why I brought up reparations, because if we're looking at really successfully dealing with these issues, we need really to go big, and reparations is that. We need to take this seriously. I think people have been just using band-aids for the longest years, and again, people are looking at public health as racism as a public health issue. We need to look at large systemic answers and tools for that.
And I also like to add that policies is a huge topic, right? To have a national impact, it takes a lot of resources and data and deliberations and strategy. But what I would want to see that, as I was talking about microaggression, micro insults, so we should have micro response also in these areas. So through advocacy in a micro form, so we can have policy in the university, we can have policy in our department, we can have policies in our council, in our city, towards really inching it towards those national goals. And I think once we can lay out that these experiences, the way we talk, the way we behave, the way we really view other has impact not only on the others but us as a whole, I would think that would allow a much more effective ways to mobilize those decision makers. Because no matter how much advocacy we do, ultimately we have to mobilize those decision makers. So there has to be a very strong advocacy, micro policy towards the broader goal of national policy.
And related to that, we're thinking about microaggressions, is that we also generally tend to police people's responses to microaggressions.
Yeah.
And that, if people, people will need to react aggressively or angrily, but that is many times not, from being viewed from people in society seen as being wrong. But when people are experiencing that, those reactions are to be expected. People feel anger, people feel frustration, and it does come out. But generally, people will use that as an excuse, saying, "Well, they shouldn't have acted in that way," and that's kind of the problem. All right, Christy, I think that's your microphone that's causing the problem. Can you type it? And Christy, we've seen over 50 cities pass these racism and public health crises resolutions. What action does this actually spark now? Frankly, probably nothing.
Well, I mean,
it's good optics. I mean, people say, "Yay, we're raising the public issue," but what does that mean for, say, Cleveland? What is Cleveland now going to do? And that's kind of the problem, is that you see a lot of people, a lot of cities, a lot of corporations, a lot of these big institutions playing lip service to a lot of these things, but not really providing any concrete actions to bring any of this to fruition.
Yeah, I mean, I agree, but I would also see this is like a beginning, right? Even having that policy as for the city would allow them, at least, and there is an opportunity for them to have opportunity to allocate resources in that areas. So at least they have a vehicle. So it may serve as a vehicle for doing something. So we shall see, because this is just a very recent. So I would not want to dismiss that, but I think this brings, it's a sensitization. It really sensitizing the policymaker that this is a public health issue, so we should not be addressing health without addressing these issues. I think that gives us a vehicle to really improve or to impact some decision makers.
Mm-hmm. Hopefully, but at the same time, it could also be used as an excuse not to do anything, saying that, well, we voted on this, we have this resolution. What more do you want? So I'm a little pessimistic.
Yeah, I tend to be a little bit more optimistic. So that's how we make a good team.
I love that you present different perspectives. I think that's really helpful for everyone involved. Are there any other questions? We're getting close to time. Christy, can you pull up the slide for next week's presentations? And Swagata and Amelia, anything else you'd like to say before I do some closing announcements?
Well, thank you for really creating this platform for this discussion, and I hope this is not an optic, as Emily was talking about. I hope we as a community at BW really we have opportunities to move this forward and make some really impact, right? We as a group of BW community, and I think let's continue this and let us know how we can be of help in any way in making this initiative forward, taking this initiative forward. So thank you.
Yes.
Well, and thank you both for presenting. You've given us a lot to think about. And as you said, this isn't a one and done. This is a whole series. And then also, we encourage folks to follow up with our two experts who presented tonight with further questions or ideas for action. Also, let us know if you have suggestions for additional topics for these Civic Lead series. I'm happy to report that our Jackets Engaged student team focused on democratic engagement is getting ready to propose a student-led session for the fall series.
Neat.
Otherwise, is someone going to say something?
No, I just said neat.
Oh, neat. Okay, well, thank you, Amelia. We're excited about that. You can see our next two sessions coming up, and the rest are posted at bw.edu/civic. Thank you, everyone, and have a wonderful night.
Thank you. Good night, everybody.
Good night, y'all.